Hello, my name is Marcus Chavez and I'm with IFARA TV. Today we will be cablecasting segments of the press conferences that were held during the 22nd CROI, which is the annual conference on retroviruses and opportunistic infections, which took place in Seattle, Washington this year. This segment will be presented by Janet Lowe, who is with the Massachusetts General Hospital and Medical Harvard School in Boston, Massachusetts. Janet talks about a double-blind, placebo-controlled randomized clinical trial that looks at the relation of cardiovascular disease in patients with HIV and then using statin therapy to treat coronary artery disease to reduce plaque volume.
Thank you to the CROI organizers and all of you for inviting me to be here. So regarding our study, just in terms of a little bit of background and to introduce why we did this study, as Judy mentioned, the heart disease, coronary artery disease specifically, has been quite noticed to be quite prevalent in the HIV population. And several epidemiological studies have now shown this to be indeed true. And so we are concerned that heart disease is a major cause of morbidity and mortality in HIV patients. And so this study that we did was to try to see if a treatment that's been proven in the general population to be effective to prevent cardiovascular events, can it have an effect in HIV patients on a surrogate endpoint of plaque measured by plaque volume seen on coronary CT angiography? So our hypothesis to the study was that statin treatment, and in this case atorvastatin, initially started at 20 milligrams and escalated to 40 milligrams if the participants safely tolerated it, to see if atorvastatin can decrease the amount of plaque that can be seen by CT angiography. And also, one of our other endpoints was to see if inflammation can be decreased in the arterial wall by the statin. So that was, our initial hypothesis. So how did we try to address this hypothesis? We performed a double-blind, placebo-controlled, randomized trial at a single center. This was done at Mass General Hospital, where we screened patients with HIV, and these are adults between ages of 18 to 60. And we purposely chose patients who did not have any known cardiovascular disease. So they could not have any symptoms of heart disease or any clinical history of cardiovascular disease. And we screened them with a coronary CT angiogram to look for plaque in their coronary arteries. And those who did have some plaque, not too much plaque though, because if they had a lot, they needed to be treated. It wouldn't be fair to randomize them to placebo. But those who had plaque that was subclinical, so it was not causing them any clinical manifestations. And then we performed a PET scan to see if their arterial wall, their vessels had any inflammation in it. So we wanted to recruit HIV patients who did have some plaque, but not clinically significant plaque, and some degree of arterial inflammation into our study. And they were randomized to atorvastatin or placebo, and the study duration was 1 year long. And after 1 year, we analyzed we had them undergo a CT angiogram again and compared, the amount of plaque volume that they had from the beginning of the study to 1 year later. And our main findings were that plaque volume decreased significantly in the atorvastatin group compared to placebo. To give you the numbers, for total plaque volume, atorvastatin decreased the plaque volume by 4.7%, but very, very surprisingly and quite a lot of concern is that plaque volume increased quite significantly in the placebo arm, and it went up by 18.2%. And we were especially interested in non-calcified plaque volume, which we thought may be the type of plaque that HIV patients had more of, as we're seeing in prior studies from our group and others, and that non-calcified plaque volume may be more prone to causing heart attacks. And so we found that non-calcified plaque volume decreased by 19.4% with atorvastatin, and it went up by 20% in the placebo arm. So those were our main findings.